Tumors in the kidney. Tumors in the kidney can be benign, like adenoma, or malignant, renal cell carcinoma. Two benign tumors commonly we see is oncocytoma and angiomyolipoma. Angiomyolipoma is what? Angio mean vessels, myo smooth muscle, lipoma fat. So three components in the tumor. The benign tumor. I hope you can see this is a left kidney, normal kidney. This is a right kidney. But here you get a black color inside the kidney. The black color means fat. So here you can see a fat under the skin, black color. So similar to that, that's mean a lot of fat inside the kidney. Here you see fat, black color, mental fat. So this is fat and blood vessels and smooth muscle, angiomyolipoma. Most of the time, 75% of the time, they are normal people, sporadic angiomyolipoma. But about 1/3 of the people have a tuberous sclerosis, a neurocutaneous syndrome. You will study in pediatric, autosomal dominant condition. So tuberous sclerosis. So it's associated with tuberous sclerosis. And the problem with this is when it's more than 4 centimeter larger size, they bleed, retroperitoneal bleeding, bleeding sometimes. A patient can come with hypovolemic shock. That's the problem of angiomyolipoma. It's a benign tumor, but it's a highly vascular tumor. No need to remove it. But if the larger size causing bleeding, then we have to do something. I don't know whether you can see, it's a normal kidney. But this is a fat-containing tumor, angiomyolipoma. This is a big tumor, so we have to high risk of bleeding. So what we do is we put a wire into the renal artery and see what is a feeding vessel, and we block that feeding vessel. That's known as angioembolization. We block the feeding artery. Angioembolization. That's a treatment for AML. So AML is a benign tumor, is a common tumor. Just remember, it's contain a lot of fat and blood vessels. Never do a biopsy. Do a biopsy, they will bleed and die. It's a benign tumor. The other common benign tumor is oncocytoma. It looks like onco. You think it's a malignant? No, it's not a malignant. It's a benign. Basically, if you see in the center, you will see a scar, central scar, a big tumor, benign tumor. If you do a histology, you will see eosinophilic, red color cells, eosinophilic cells, oncocytes. But sometimes in CT scan, difficult to differentiate whether it's a benign or malignant. Only histology will tell. So common benign tumors, adenomas, oncocytomas, angiomyolipoma. Common malignant tumor is renal cell cancer in adults. Common cancer in the pediatric is a nephroblastoma, also known as a Wilms tumor. So I just go through what is Wilms tumor. It's classically present at 4 to 5 years old. Mother diagnoses it. Mother give a bath to the baby. In a bath, mother feels something, a tumor in the loin. Otherwise, baby looks very, very, very normal. Nephroblastoma is a good cancer. You know, if you remove the kidney, they will survive. Don't confuse this with the neuroblastoma. Neuroblastoma is a very bad cancer. Occurs in an infant. They will die most of the time. Aggressive cancer. So here you can see CT scan. It's a big tumor. That's a Wilms tumor. Another tumor is sometimes you will see in the kidneys, in the renal pelvis tumor. Just now I got a referral from oncologist, a patient from, that patient came from the hematuria, there was a tumor in the, similar to this, tumor in the renal pelvis. So that is not the renal cell cancer. This is a tumor in the collecting system. So epithelium is a stratified squamous epithelium, transrenal cell epithelium. So transrenal epithelium, so they develop transrenal cell cancer. So this is different from renal cancer. But the CT scan, they come with the tumor in the kidney. So this is not so common tumor. You can see a tumor in the upper calyces and lower calyces. So it's a urothelial cancer. Again, you can see a malignant looking tumor appearing from the renal pelvis. So it's a transrenal cell cancer. So they come with the visible hematuria because these tumors bleed. So pelvis, ureter, they come in the blood in the urine. Right. So renal cancer is a common cancer. It's a deadliest cancer. It's a more lethal cancer. I used to say prostate cancer is the commonest cancer. Bladder cancer is the costliest cancer. A lot of money you have need to manage the bladder cancer. They won't die. You cut, again recurrence, cystoscopy, a lot of money. Costliest cancer. The renal cancer is the deadliest cancer. Common in males because of smoking. It heavily associated with smoking. Risk factor smoking. And I did a research on this, a prospective study on 250 renal cancer, where the risk factors are hypertension, obesity, and diabetic as well. Then there are some genetic conditions like von Hippel-Lindau syndrome. Just remember that name. Von Hippel-Lindau syndrome can cause early cancer. They come with the 30s and 40s. And autosomal dominant condition. They come with early age, 27, 50s, 40s, with the cancer. Bilateral cancer. Both kidneys are affected. Multifocal cancer. Few years back, I have operated an army soldier. He had a big cancer in the right kidney and 5 cancer in the left kidney. Just imagine, you had to remove both kidneys and the problem. So luckily we managed without removing the both kidneys. That's your level, no need to know that, right? So risk factors. So pathology is cancers. Most of the cancers origin from proximal convoluted tubule. There are discrepancy with the book, but just remember that most of the tumors coming from the PCT. So tumors are usually at the cortex of the kidney. And the common histology is a clear cell. And common location is the upper pole. In pathology, we can ask what kind of appearance you will get in a renal tumor. So if you cut it, they will get a golden yellow color because of lot of fat inside. Golden yellow color. And you will get areas of necrosis because these tumors are highly vascular tumor. The reason for that is I'm not going to explain. They are highly vascular tumor because of the VHL pathway. And also you see some areas of necrosis, areas of bleeding, and areas of tumor. So it will look like a very appearance. So it's a variegated appearance. You get a variegated appearance. So different layers of tissue. So common histology is a clear cell histology, 75% clear cell. What is clear cell? If you see these cells under the microscope, because they contain a lot of fat and glycogen in the cytoplasm, during the H&E staining, these all get dissolved. So if you see under the microscope, the cytoplasm will be clear. That's why it's known as clear cells. Clear cells. So there's other histology is papillary. I don't think you have to know the other types of histology, but just remember the common histology is clear cell. Second common histology is papillary. There are more details, but your level no need to know that. How they spread locally, they can go to the adjacent organs. Then they can go to the lymph nodes. But quite commonly, the lungs, 50% of the time, they can go to the bone. And this is a notorious tumor that grows into the renal vein and grows into the IVC, and it can go to the right atrium. And this is a picture taken in the Guy's and St. Thomas Hospital in England. It also, these pictures are there in your Surgery International. And you can see this left tumor grow into the renal vein and goes into the IVC. This is the tumor after removal. You can see the tumor thrombus going into the renal vein and going into the IVC. This is one of the only tumor that grows into the vein. Very rarely, there's another tumor. Hepatocellular cancer can grow into the hepatic vein. But this is a classic tumor, grows into the IVC. Whenever it goes to IVC, it's a big problem for us. Doing surgery is not easy. Sometimes it goes to the heart. You can see this picture. We are opening the right atrium and tumor thrombus is there. Sometimes it goes to the heart. So it's the only tumor that grows into the vein. You can see a renal cancer in the upper pole. Upper pole is the commonly affected pole. And they can go to the spread to the lungs. You can see a cannonball appearance. The pathological grade we use here is Furman grade. 1 is good grade, 4 is a bad grade. The good prognosis type is chromophobe type. Papillary is better. Clear cell is a bad, aggressive cancer. Common presentation of renal cancer nowadays is incidental diagnosis, because we do a lot of scan for some reason they find that tumor. So common presentation is the incidentalomas. But we know that classical triad, painless hematuria, flank pain, and the loin mass. Another point you have to remember, renal cancer is notorious for paraneoplastic syndrome. Because of this reason, we tell this renal cancer because they secrete the parathyroid-related protein and hypercalcemia, secrete the renin, hypertension, secrete the erythropoietin, polycythemia, and they affect the liver function and a lot of paraneoplastic syndrome. So medical students remember this. Because of that, we used to tell it's a medical student's tumor or internist tumor. Because usually whatever you study in paraneoplasty, you will never see. But here is very common. Again, you can see left kidney normal, right kidney there is a tumor, a lot of necrosis in the middle. It's a typical picture of clear cell renal cell cancer. But we do, most of the time we remove the whole kidney, but nowadays we only remove the kidney and leave the kidney. It's known as partial nephrectomy, and we suture it. This is radical nephrectomy.